This is the week when normally you would all be coming to Charing Cross 2020. And during the course of it, we want to release this webinar. COVID-19 has hit the human race a little bit like First World War or the Second World War. And the moment it's a very serious insult, and it's very inappropriate for us to talk about CME and vascular reconstructions whilst we're being surrounded by death threats all around us. So what I thought would be best is if we choose really prominent vascular figures in different parts of the world of all different ages, but how you're chosen is because you have an interest in Charing Cross, you're very supportive of Charing Cross, and you're in different geographical positions, different status and stratas of life, different backgrounds, but you've all had different experience of the COVID-19. The first point that we need to mention is how has COVID-19 affected your environment and practice? And I'm going to start with Enrico Ascher because Enrico has had experiences of how it's affected his life today.
Yeah, well, thank you, and it's a pleasure to be here participating. I wish I was there in London in your meeting, which is fabulous and very exciting, and I really enjoyed it very much. Unfortunately, we were hit with this horrible pandemic, and particularly in New York City and New York State, we have been hit very, very hard. Just to give you some numbers, so far we have had over 130,000 patients with COVID-19. We had over 35,000 hospitalizations and over 9,000 deaths with diagnosis of COVID-19. Just in Brooklyn, which is a very endemic area, we had close to 35,000 admitted patients, diagnosed patients in Brooklyn. And this is double what you have in Manhattan. So we had been particularly hit because we don't have as many institutions in Brooklyn as they have in Manhattan. Yet we have double number of cases that they have. All of us, nobody has been spared of not doing only what we know how to do and our specialty, but actually extending the services to other particular needs within the hospital.
You're describing the huge New York, and you're already drawing differences between parts of New York. Can you relate why it is that some parts of New York are affected more than others as far as you can see? Is there an obvious reason for that?
I think the main reason that comes to my mind is because the population, the average population in Brooklyn is poorer than the one in Manhattan.
So there's a poverty. Poverty
yes.
is associated with the proliferation of COVID. Milano has been very hit. Other parts of Italy less so. Would you please comment on that, Roberto?
Milano was the really endemic, the most important endemic area in Italy, but not in particular Milano, but Lombardia is the region of Milano, and there are two towns close to Milano and Lombardia, Bergamo and Brescia, comes the very, very important, the first area of diffusion of the disease. The real reason, I think that nobody know exactly, but the idea is that in Bergamo, in Brescia, there is a lot of very strong workers that work outside from the town. They go every day outside, and they go back, and they go through all the Lombardia, through all the north of Italy.
There's an English word for that. They call it the footfall. In other words, where the buses go, where the undergrounds go, where the people go, if there's a lot of movement, that's where it seems to favor the virus spreading. That's what you're saying, yes?
Yes, yes, yes.
So that's,
another reason that is possible, the origin of this. There is a match of the championship in Milano, the origin of the pandemic, the end of the February, between the team of Bergamo and Valencia.
oh, yeah.
and in Stadio of San Siro is the stadium. In
Oh,
the
we
center
know
of
about San
Milano,
Siro.
there are 40,000 people all together, very, very tight. Immediately 2 days, 3 days after this, there is an increasing of the pandemic. Another
So
possible,
COVID-19 enjoyed San Siro. It had a very good day there, didn't it?
yeah. And another, the third possible that the epidemiologist report that there is an airport, Oriol Serio, close to the Bergamo, that remain open for a long period.
Makaroun, tell us your comments on how has the environment and your practice been affected by this virus, please? Pittsburgh.
Well, thank you again for having me. And I, like Enrico, I wish I was in London instead.
Oh yeah, me too.
But
All of us.
we have been actually lucky in Pittsburgh. We have had very few cases, and certainly the system has not been overwhelmed.
Oh, great.
The Pennsylvania borders New York. And when the cases in New York started increasing, they put the lockdown on all of Pennsylvania, but we are about 6 hours drive away.
Okay.
So our region was locked down before the big increase in the cases.
Mac, that's very interesting. When you hear what Enrico says and when you hear what Roberto says, there's communication between people. I don't know whether you use the word in London, but we talk about footfall. There are people who can go from one part to another. That seems to be a factor we've heard already in this discussion.
We have really been affected only from the perspective that we stopped essentially all our work. So we are doing only emergencies and urgent cases, which tends to be about 15% of what we used to do. We have been recruited to help in placing lines for dialysis and for maintaining the lines of patients. But in general, our life has been come to almost complete standstill. And now we are struggling with the facts of restarting and how do we go back to catch up with all the patients that we have delayed and canceled.
Wow, amazing, amazing. So, Mac, I think we should call on Jürg Schmidli to tell us if there are differences in Switzerland from what you've heard in Milano and two parts of America. Then we'll go to Gunnar for Bavaria and Rebecca for Mexico. Can we have Jürg on here?
Thank you very much, Roger, for being here. We were quite lucky in Switzerland. We knew that what happened in Italy, and our authorities shut down the country quite fast. So most of the hospitals had about 2 weeks to prepare for the COVID patients, and only in cities at the border like Geneva or Lausanne, or even in Lugano, which is quite close to Italy, they had a lot of COVID patients from the beginning. But in the Swiss part, in the Swiss-German part, we had quite a few patients there.
You've done very well in Switzerland, haven't you?
Yeah, we were lucky. I think so. We had about 60,000 workers from Italy that crossed the border every day, and we think that this is one of the source of the infection, but also people having been to Italy, to ski resorts to Italy, and they came back with the virus.
Gunnar, please let us know how it is in Rosenheim.
Yeah, so Bavaria is it is quite different in all the regions in Bavaria, and I can tell you that Rosenheim is the #1 spot for COVID-19 within Germany. We have most of the cases out of Germany, and this is because we are close to Italy, to Austria, and we have a lot of people who were skiing in all the ski resorts right now, and about 10% of our population are infected. So that's what Rosenheim is about. And our hospital now is treating 200 COVID-19 patients currently. So we have like 600 beds, and 200 of those are COVID-19. So we're quite heavily affected.
In Rosenheim's case, it's an area where there's a lot of travel through there from Innsbruck and so on, from the Alps, from Italy, etc. So do you think that's a factor? Because this is what Enrico was talking about in different parts of New York. And we heard from Makaroun that as soon as the shutters were put up, this benefited Pittsburgh. So there seems to be a theme going through here already. Would you agree with that, Gunnar?
Yeah, I would agree with that.
So if I may go to Rebeca now, Mexico, you've heard in these different parts of the world. Mexico is a beautiful place, of course, but I understand it's been very tricky for you in Mexico, and that's why you're on this call.
Yes, it's very tricky, the numbers, because we are very different from, for example, New York, that they are, or United States, that they are a lot of tests. We don't have it. And that's a problem because the government decide to have a special kind of test that it's called Centinela test, that you don't test everybody. But the number of cases right now is 8,000 cases only. But the estimate is around 50,000 cases, but we don't know where are they because they don't test everybody. So
you suspect there are many more than you're hearing about?
Yes.
Can I say one thing, Roger?
Yeah, of course.
The problem in Italy is that you are the first state in Europe with COVID, and has been an initial delay in restrictive measure. Really, you have some delay. You have 2 weeks of delay, but really because you are the first country interested by the virus. So the other country have the COVID 1 week or 2 weeks or 3 weeks later. It was easier for the other
to learn. You learn from Italy, actually.
Yeah.
Absolutely.
Yeah. For example, for Switzerland, I think that is easier after observed what happened in Italy to stop immediately and to close down everything. You are the first country. This is the problem. You understand?
Roberto, I want to go to the second question now, and I'm starting with you, and the other panel members can suggest when they wish to speak on it. But the next point is whether you consider in your particular health system where you are, did you have the sense that your country, your environment where you are, were you ready for this virus, or were you caught unawares? Did you feel you were, as the English sometimes say, on the back foot, or were you ready for the fight? Start with Roberto.
You are not ready
No.
for a situation like this, for an emergency, a global emergency, a war emergency.
Yeah.
Because everybody said a war emergency, so you are not ready at the beginning. I think that you need almost 2 weeks to start to be ready. And in these 2 weeks, the first problem was where to put the patient.
Yeah.
Really, I've seen some Chandler terrible. The patient arrived on the trial of the triage of the hospital, and you don't know what to put, where to put.
Where to put them. Were you ready in New York for this virus?
No, we were not ready.
No.
We did not expect this kind of impact on the service that we provide on a daily basis. We had to very quickly increase the capacity in the hospitals for 50%. You had to create beds 50% more than we had. This was a mandate by the governor because the epidemic was horrendous. And
what about you, Mac, in Pittsburgh? Were you ready or not ready?
As I mentioned, we had a little bit of a lead time to react. And in Pittsburgh, our system was actually very ready. We had the time to develop our own testing. We had the time to develop actually our own vaccine that's undergoing testing now. We had the time to, before we saw the first patient hit our doors, we had almost 3 weeks to prepare. So the system, at least our hospital system, was ready.
It tells you, Mac, it tells you what a spectrum in the different parts of the vascular world, what a spectrum of difference there is. Because in Pittsburgh, you're actually able to say to me, COVID came, but we were ready. We were well developed. we also had the opportunity, just a couple of weeks of delay, which was helpful compared with New York. But basically, you just said we were ready. And you're the first doctor, vascular doctor, I've heard say that. What was it like in Switzerland, Jürg?
Yeah, about the same.
You were ready.
I think so, because we had this contingency plan that was activated quite early by the authorities. And maybe 90% of the hospitals, they really could prepare.
Yeah.
We did not have enough tests. At the beginning, we did not have enough masks.
Exactly.
We were ready to prepare.
Yeah, well, wow, that's important. Yeah, so Rebeca,
Yeah.
Mexico.
We don't have anything. I mean, we have N95 masks. I bought it for myself because some institutions, principally public institutions, they don't have enough equipment.
Rebeca, I'm going to quote you something. See, we've just heard from Jürg Schmidli, professor in Bern, and Makaroun from Pittsburgh, how ready certain parts of the vascular community were. You've told me outside this, and you may repeat it here, that you have been in fear of going to work. To do your work in vascular environment, the fear of where the virus was all the time was such that you were in the sense that it was very, very dangerous for you even to go there. Is that correct?
Yes, that's correct. We don't know if the patient is infected or not because they are not testing them. So we have to take our own protection not to get infected.
Times are difficult. Incisions are not a good idea for anything other than most emergency. Do you see in your famous department a tendency to do more endovascular than open than you normally would, or not?
Yes. I've seen to see more endovascular,
yes,
for many reasons.
Yes.
First, because all the beds of intensive care was occupied, and so you have no more beds for intensive care. So it was very difficult to do open surgery without intensive care on aorta.
You see, Roberto, what you're saying, we've got to learn from what you're saying here. Actually, that virus has influenced what type of vascular surgery we did when the limited numbers can be done. It's not a time where we think of doing incisions and the risk of infection. In the emergency situation, it is alleged that there are fewer, because of the COVID, there are fewer transplants, fewer cancer referrals, and because of extra risks. Would you all comment upon the other than vascular not being done, other urgent matters not being done through the virus, and whether this is the case in your center? And with you, Roberto, so you start briefly, then we'll go to Enrico and Jürg, and we'll go around and listen to that. But please begin, Roberto.
Yes, in my center, I've seen the number of aortic emergency not change it, not increase it, not change it. And I have seen increased a lot the number of peripheral disease, emergent peripheral disease, ischemia, and others.
Wow.
I've seen a mix of pathology. For example, increased the number of support to cardiac surgery, ECMO, Impella, and so on. Increased the number of pseudoaneurysm that you do for these maneuvers, and not increase the number of emergency for car accident or for other problems. But generally speaking, the number of aortic emergency stable, completely stable.
So in general, that's true in our hospital and throughout Germany, is that emergencies like patients who present with stroke or a heart attack got down by 50%. So those
50%.
50%. So independent of vascular in general. So emergencies also went down a lot. Heart attack and stroke, and also all the traffic problems. There's no traffic. We don't see any patients coming from car accidents anymore.
Now, Jürg, please. What
Yeah,
did you?
we saw the same thing. We didn't have one ruptured aneurysm a
Wow.
whole month, which is completely unusual.
Yeah.
We
Well,
think,
Makaroun and then Enrico. Mac, what do you see?
Somewhat similar and somewhat different. We actually had 6 ruptured aneurysms in a time about 2 weeks. Our predilection anyway for most emergencies is to try and do endovascular in the first place, so we did not really change too much what we did. The trauma in general is down because actually cars on the street are way, way, way down. And actually insurance companies are reimbursing all the drivers for the premiums that they paid and they're not driving. We are continuing to do the cancer surgery that has not really stopped. The elective work, as you mentioned, is down to almost none.
Yeah.
But in general, the emergencies have stayed about the same as it had before, but we may be privileged in a way where we are in terms of not being overwhelmed with COVID.
Enrico, what are you going to say?
Yeah, well, I agree with some of the comments in terms of the number of emergencies. We have much less emergencies, much less heart attacks coming to the hospital. And the reason I believe this is happening is because patients are afraid of going to the hospital.
Absolutely.
They say, might as well take an aspirin at home and wait to do telemedicine. So I think we have seen less of all these. And in terms of a question that you asked was very important, is are we affecting those patients who have potentially cancer and other things? That's a very important question. There's a study which I have not read, but I heard about from an English investigator who says that in 5 years from now, you're going to see the negatives of not screening those patients.
Let's consider the impact on the backlog of work that's going to have to be done once we're back to near normal.
We do have a large backlog that has already developed, but we have taken a systematic approach about how to go about it. Our institution has increased the testing, so now we are going to be testing all the preoperative patients. And we are collecting all of the backlog from all the services. And we have a centralized clinic that will get them ready for the OR.
Right.
The problem now is going to be a logistical problem. How many ORs can you reopen? The anesthesia care, how many nurses are sick and cannot show up. So the block time, who can operate and when not. The backlog, our system does over 2,800 procedures a day. So you can imagine in this time frame of about 5 weeks of doing very little elective work, there's a very large number.
I want to ask you something because Roberto Chiesa Milano has got a big center and he's talking about clearing out and cleaning before anything. What's your answer to that?
Well, again, we are very limited in our exposure. We have one ICU that is full of COVID patients.
Completely
and
different.
one unit that has all the patients being evaluated. So our hospitals in general still have a lot of capacity. So now we are trying to actually restart gradually and how to prioritize both the patients and how to actually provide a framework for the cases to restart with minimal risk.
Jürg, what about if it's like the usual, then this in Bern will be very similar to Pittsburgh. It's more like Pittsburgh than Milano.
I think so. We have about 1% of health professionals that are infected. And we expected to have much more, maybe up to 30%, but it's not the case. And that's why we don't think that to restart is such a big issue. But I wanted to make another point why people stay home. They were told to stay home because not only because they will get infected in the hospital, but also because the hospital was overloaded. So they just suffered more at home.
Yeah, that's what we've all been told. And that was about the earlier part of the discussion about the footfall. Rebecca, you've heard Pittsburgh, you've heard Bern, Switzerland, you've heard Milano, Mexico, please. What do you learn about?
I want to go to live in Pittsburgh.
Yeah,
really. I love Mexico, but I know that we are very far from what it has to be. So we are trying to flatten the curve. We are trying to stay at home. We don't have any date to go again to work as normally. The government says until the end of May. So it's one month and a half more staying at home. We are in phase 2. They don't want to take the phase 3 yet.
Yes.
But we have to stay at home right now.
I want to introduce the question of the fact that at the Charing Cross Symposium, we were ready with lots of first to podiums, a lot of new data, which is important to communicate, not necessarily in the subjects with all of your expert, but things like all the new latest findings of paclitaxel and limus drugs and whether they're safe or not, all there. So it seems to us that it's still the era when we must be struggling with one aspect or another of the virus, and that is going to be for some time. But looking ahead, we can't be certain that even in September, when, for example, the ESVS has a meeting, or the Deutsche Gesellschaft in September, and our planned CX Aortic Vienna, we can't be certain that an open event will take place then and there'll be normality. Far from it. So we're thinking we're going to have to plan for digital communication and virtual Congress. That's our thinking of Charing Cross. Would you please comment on that? Or do you take a different view? Like in Pittsburgh, you'd probably be able to hold a meeting straight away, but I doubt we would in Europe. Would people comment on that, please?
Well, I don't think we will have a meeting in Pittsburgh soon. we are all at home, and that's why we have very few cases.
Of course.
The streets are empty. You can walk in the middle of the street and you can be sure that you're not going to be hit by a car. But the SVS has canceled its meeting, and we are moving that part to at least part of it will be a virtual meeting.
Excellent.
We are actually discussing with the European, with the ESVS, what we are doing so that they can learn from our mistakes and what we are planning.
Yes.
I think going virtual is something that we have to do. Most of our meetings are now virtual. I'm spending more time in front of this camera and computer than I ever did in my entire life.
Exactly.
Actually, I had a virtual dinner with my friend last night. So
did it taste good, or you smell it? Did you?
We could not smell. That's the problem. That's the COVID problem too.
Well, okay. So Enrico, what's your view? What about the vegan?
I think nothing will ever replace a live, presence of your colleagues meeting where you meet, you talk, you discuss. So, but right now we are in a situation that we have no other option but actually to go online. But that's not going to replace in the future our standard congresses where we meet the people, we talk to them, because there's more than just the information. It's the interaction, the human interaction that's very important in our profession.
Do you think we'll ever get to using the Latin term status quo ante, shall we ever get back to the state we were before the virus, or is this going to affect us permanently? So why don't we start with Mac?
Well, I'm afraid that until we have the science catch up with this virus, I'm not sure that we will ever know how we are going to return. I think we have to learn how to live with it for the foreseeable future. And it is not something that's going to be done in 3-4 weeks or 3-4 months. It may be a year or two. But I hope we all go back to where we used to be.
Yeah, we want to get there, right? So Enrico?
I think what we learned this time, and I think is going to be here to stay, is telemedicine. That is going to cut down a lot on the patients having to be seen in the office. I think it's going to be an improvement, actually. Less costly and more effective. I think telemedicine is going to be here to stay.
Telemedicine, thank you. So Rebecca, what do you think?
I think this is going to cost us a lot not to touch the patient. Telemedicine, it's good for now, but sometimes you have to touch the patient, you have to check it, and it's difficult by this kind of communication. So I hope this will be soon ended, and in the best way. I don't know how many months it's going to take us.
What do you think, Jürg?
Yeah, we are hoping for a vaccination. We have three
Yeah, of
companies
course.
in Switzerland that promise us to have a vaccination by end of October. And in the meantime, we hope that the second wave doesn't hit us too hard.
Well, that's what everyone's concerned about. What about the danger of the COVID for us at work? What's it like in Rosenheim?
So we are also quite ready, I would say. Nevertheless, if we are in contact with the COVID-19 patients and a close contact, there is still the risk, and you can just minimize the risk, and we cannot exclude that. I think we have to live with this, and we have to take all safety precautions and wear the masks and do all other things. And have to test. We have to know who's positive and who's negative in order to.
Health Organization says three things you do: test, test, and test, and then you know who's got it and who hasn't. And it's expensive to do that, but not every country is doing that, including my own.
And what we're doing actually here in our institution, we are doing a lot of CT scans, much more in our department. Because with that, it's quite sensitive and it helps a lot. And if you see really typical signs of COVID-19, you can say, okay, that's a patient who has that, and it's even faster than a test. So currently we are doing 25 to 30 CTs just because of COVID-19 in order to test.
But I hadn't heard CT scans being done. That's an interesting thing for the film to hear that. I have heard that certain sophisticated aspects of ultrasound are being used to assess the lining of the lung and pick up pneumonia with some success. But that's a hit or miss thing. And I don't think we've heard either for CT or ultrasound how reliable it is. The concept of the testing that we talk about, it's simply not happening all over the world, is it? As the World Health Organization would like.
Roger.
Yes, please, Enrico.
I just want to add one thing that I don't think we should overlook, which is the influence of the family into this whole thing.
Oh, yeah.
The family of the surgeon or the provider, it's a big deal because they are very concerned. And you spend 12 hours working and putting lines on these patients. Yeah. Then when you get home, you have small children, you have a wife, you have your grandparents. I mean, it's a big problem, and this is affecting a lot of us. I mean, every day is something that we worry about. How we're gonna, what our responsibility towards our family.
In certain parts of the world, the shortage of doctors is encouraging that final year medical students should be raced through their final examinations and brought into practice. Do any of you have any experience of that, and do you favor that? It will depend, I think, on the requirements of every local center. But I would like to know, for example, whether Rebeca, in Mexico, if you're short of doctors, would you consider using final year medical students as doctors? What do you say?
Here in Mexico, all the medicine students are at home.
Okay.
They are not allowed. Not allowed to go to the hospital because they are not prepared and there are not enough equipment to protect them.
Is anyone, any of you, seeing people being raced through their finals to be able to make contributions, or is that just newspaper talk?
Now we had that at NYU. We had 50% of our senior class graduated already, and many of them were giving jobs as residents.
Okay.
And those who are not giving jobs as residents, they were hired, paid as residents to help in this endemic.
What about Pittsburgh?
This has not happened here. We have an interesting organization of medical students that actually has figured out a way of helping without necessarily jumping into the hospitals because we don't need them. They are actually providing childcare for the physicians and the doctors who cannot be at home to take care of their kids. They are also volunteering into small clinics into the disadvantaged areas of the city. So the medical students are stepping up and helping, but not necessarily as physicians directly yet.
Now, in these last two questions, I want to listen to all of your views on this, and I'd like to hear what you have to say about it. This virus, COVID-19, the question is, what would you have liked to have known? If you could say to yourself, if only I had known what I know now, what would I have done?
One of the things that kind of always puzzles me, and I wish I had the answer to, is the rate of prevalence of the asymptomatic patients around us, which will help us deal with many of the other questions that we have to deal with.
Okay, next one. Who's going next?
Oh, I can quickly just mention, I would have called the governor, our Governor Cuomo, and asked him to expedite the buying of ventilators, because we had in the beginning an issue.
You need more.
A major concern on having that. So obviously we could prepare ourselves better.
Yeah.
I think that right now we are prepared for the next pandemic, but who knows when this is going to happen. Hopefully it will never happen, but we are much better prepared in terms of government, local, state, and federal.
Now that we know that we were hit only slightly, that we would not shut down the whole system.
Okay.
Completely. I would have learned that.
Very good. Gunnar?
Yeah, I think the one issue here is that we, at the very beginning, we didn't have enough tests. So Rosenheim was only able to do like 30 tests by a local lab. At very beginning, Munich helped us, but then they had also a lot of cases. Then we were on our own, and we just didn't have the possibility to test patients, and that's a big issue. So we are right now we are fine, but that was the major issue at the very beginning.
Thank you. Now we go to Milano. Roberto, if only you'd known what you know now, what would be different?
I agree, but I repeat, the thing was so sudden that it was impossible in the first day to do something different.
You couldn't do it different.
One thing is very interesting that we learned and we do as soon as possible, to create hub for every type of specialty. So you create an hub for cardiovascular emergency, all the you create a hub for oncologic surgery,
Yes.
an hub for emergency surgery. And this is very important because you can do all emergency, all very important thing for vascular surgery in one major hospital in the region, and to use all the other hospital to cure the COVID patient. This is very important.
You would tomorrow you would have a different system of organization so that different things took place in different hospitals. Yeah, interesting. During this difficult period of this COVID-19, what has been your most difficult decision you had to make? Roberto?
The most difficult decision was to not operate some patient in a very, very critical situation. For example, thoracoabdominal patient with aneurysm 7 centimeter, 8 centimeter, 10 centimeter, or arch 7, 8 centimeter.
Normally you would do it and you were afraid that they may burst, but the risk was too great. That was awful for you. Thank you. Enrico, you're next.
Yeah, well, honestly, I'm not going to be selfish, but one of the issues that I struggle with is whether I should, because of my age, put myself in that situation of being 10 days on call, 24 hours on call a month, with COVID patients in 2 different institutions.
Yeah.
And I did not see too many of my colleagues in my age group doing it. So I struggle a little bit with that, but I decided to just go ahead with it.
Well, you're a saint, and there's a
Not
place
really.
for you in heaven. Let's go to Jürg Schmidli.
Well,
Most difficult decision, Jürg.
We had the same discussion with thoracoabdominal patients, but we had a solution with the chief of ICU, and he told us we should operate on the patient before we get the big load of the COVID patients. So we operated on some of them, and this still worked out well. So actually, the hard way was to find the decision with others together.
Thank you. Gunnar?
The same applies for us. So we treated some patients, we didn't treat them or just delayed the treatment because we needed the ICU, and this was covered by COVID-19 patients. So there were no anesthesiologists available. So that's that's an issue, but we couldn't solve that problem.
Thank you. Mac, your most difficult decision during this COVID experience?
Well, it's similar to the experiences of others, which is delaying care, but maybe I'll go back to something a little bit more humorous. But the most difficult decision for me is to stop seeing my grandchildren, because my children would not let me see them anymore.
Okay.
The other thing was essentially trying to make sure that most of our employees and personnel are protected by sending them home and trying to make sure that their jobs are protected in terms of not being laid off, which has happened in some of the medical systems in the US.
Yes. Thank you, Mac. Now we're coming to Rebecca for the last comment. And I did it on purpose, Rebecca, because you've had a tough time. What has been your most difficult decision during this COVID virus period?
Going to the hospital, because it's, yes, it's like gambling.
Whether you should go or not, yes.
Yeah, because you don't know if it is infected or not. I mean,
yes.
It's like a gambling game. So it's difficult to know. You have to protect yourself for everything.
Thank you for
that's the problem.
Rebecca, all of you, I have so much enjoyed listening to your experiences. I hope you feel that it's been worthwhile and appropriate to report on what vascular surgeons are doing in different parts of the globe affected by COVID-19. And I thank you all very much indeed.